You don't know me, but my name is Torma Ted. I was a Marine in Iwo Jima. I lost my best friend. There. The trauma caused the right side of my brain to ignite and overpower the left. I became a savant. Then I became a psychology major and PMHNP. I can't help my Marine instincts. I can't. They'll leave no man behind. I created this channel to share knowledge and create understanding. That way I can send my brainwaves out to help others. And not my soul.
The big picture: why antipsychotics cause movement problems. Every antipsychotic works by blocking dopamine D2 receptors in the brain's psychosis pathway, mesolimbic tract. The problem is that dopamine D2 receptors also live in the brain's movement highway, nigrostriatal tract. When you block D2 in the movement highway, the body loses its ability to coordinate smooth, voluntary movement. And that's when the trouble starts. Think of dopamine as the oil that keeps the movement engine running smoothly. Block it and the engine starts grinding, stalling, and misfiring in 4 very different ways, each with its own timeline, presentation, and treatment. The 4 movement disorders. Meet the time zone gang. The single most important concept for boards is that each movement disorder has a different timeline of onset. Learn the timeline and you'll never confuse them. Think of them arriving at a party one by one. Dystonia shows up in hours. Akathisia arrives in days to weeks. Parkinsonism strolls in over weeks to months. And tardive dyskinesia crashes the party months to years later and refuses to leave. Acute dystonia, the first responder, hours to days. What it is. Acute dystonia is the first movement disorder to appear, typically within hours to 5 days of starting an antipsychotic or increasing the dose. It consists of sudden, sustained, involuntary muscle contractions that twist body parts into abnormal postures. The classic presentations are torticollis, neck twisted to one side; ocular gyric crisis, eyes rolling upward and getting stuck; trismus, jaw clenching shut; opisthotonus, back arching like a bow; and laryngospasm, throat muscles clamping. This one is a medical emergency because it can obstruct the airway. Who gets it? Young males are at the highest risk. This is the classic board question demographic. Other risk factors include high-potency FGAs. Haloperidol is the biggest offender. High doses, IM/IV administration, cocaine use, and a family history of dystonia. Among SGAs, dystonia is uncommon but has been reported with risperidone, approximately 7.2% with long-acting injectable, aripiprazole, and ziprasidone. Why it happens? When D2 receptors in the nigrostriatal pathway are suddenly blocked. The balance between dopamine and acetylcholine in the basal ganglia is disrupted. Acetylcholine becomes relatively overactive, causing the sustained muscle contractions. This is why anticholinergic drugs fix it. They restore the dopamine-acetylcholine balance. How to treat it? This is a medical urgency. Patients are terrified and in pain. The treatment is fast and effective. IM benztropine, cogentin 1 to 2 milligrams, or IM diphenhydramine, Benadryl 50 milligrams. Relief occurs within minutes. After the acute episode resolves, start oral benztropine prophylaxis, 1 to 2 milligrams BID, to prevent recurrence, especially if the antipsychotic must be continued. If the patient has recurrent dystonia despite prophylaxis, consider switching to a lower-risk antipsychotic, quetiapine, clozapine, or olanzapine. Board pearl, laryngospasm, dystonia of the laryngeal muscles, is the only form of acute dystonia that is immediately life-threatening. If a patient on an antipsychotic suddenly develops stridor and respiratory distress, think dystonia first, give IM benztropine or diphenhydramine stet, and prepare for emergency airway management. Memory trick: dystonia equals days. First to arrive equals diphenhydramine or benztropine fixes it. Akathisia, the restless tormentor. Days to weeks. What it is: akathisia is the most common extrapyramidal side effect, and arguably the most distressing for patients. It typically appears within days to weeks, most commonly within the first 3 months, of starting or increasing an antipsychotic. It has 2 components: a subjective feeling of intense inner restlessness, I feel like I'm crawling out of my skin, I can't sit still or I'll go crazy, and objective motor signs: pacing, rocking, shifting weight from foot to foot, crossing and uncrossing legs. Approximately 50% of all EPS cases are akathisia, and about 25% of patients on FGAs develop it. SGAs cause it at lower rates, but it remains a significant problem. Even aripiprazole, despite its favorable side effect profile, has a notably high akathisia rate. Why it matters so much. Akathisia is the #1 reason patients stop taking antipsychotics on their own. Even worse, akathisia has been linked to suicidality, aggression, and violence. A patient who is akathisic may be misdiagnosed as agitated or psychotic, leading to an increase in the antipsychotic dose, which makes the akathisia worse. This is one of the most dangerous clinical traps in psychiatry. The critical distinction: akathisia versus anxiety versus psychotic agitation. This is a high-yield board topic. Akathisia is a motor phenomenon. The restlessness is in the body, not the mind. Patients with akathisia don't have racing thoughts, worry, or panic. They have an irresistible urge to move. Anxiety is cognitive: worry, dread, catastrophizing. Psychotic agitation is driven by delusions or hallucinations. The treatment for each is completely different, so misdiagnosis has serious consequences. How to treat it? The treatment hierarchy for akathisia is different from other EPS. Anticholinergics, benztropine, are less effective for akathisia than for dystonia or Parkinsonism. A 2024 network meta-analysis in JAMA Network Open found the following efficacy ranking for antipsychotic-induced akathisia. Mirtazapine 15 mg per day showed the greatest efficacy, SMD-1.20, followed by biperidone, SMD-1.01, vitamin B 600 to 1,200 mg per day, SMD-0.92, with the best efficacy tolerability profile, trazodone 50 mg per day, SMD-0.84, mianserin 15 mg per day, SMD-0.81, and propranolol 20 mg per day, SMD-0.78. Clonazepam, zolmitriptan, and valproate did not show significant effects. The most important first step is always dose reduction or switching to a lower risk agent. Quetiapine, clozapine, or olanzapine have the lowest akathisia rates. Board Pearl. The exam loves to present a patient on an antipsychotic who is restless and agitated and ask whether to increase the antipsychotic dose. Wrong makes it worse. Or recognize akathisia and reduce the dose/add propranolol or mirtazapine. Correct. Memory trick. Akathisia equals agony of restlessness equals add propranolol or mirtazapine, not more antipsychotic. Screening. Tool, the Barnes akathisia. Rating scale. BARS is the validated tool for assessing akathisia severity. It rates observable restless movements, subjective awareness of restlessness, and associated distress, plus a global severity item. Drug-induced Parkinsonism. The slow creeper. Weeks to months. What it is. Drug-induced Parkinsonism, DIP, develops over weeks to months and looks exactly like idiopathic Parkinson's disease, bradykinesia, slow movement, cogwheel rigidity, ratchety resistance when you flex the patient's arm, resting tremor, pill-rolling tremor at rest, shuffling gait, masked faces, expressionless face, and postural instability. The key difference is that DIP is caused by medication and is usually reversible when the offending drug is stopped or reduced. The pooled prevalence of antipsychotic-induced Parkinsonism is approximately 20% across studies. Who gets it? Older adults, especially women, patients on high-potency FGAs, and patients on higher doses are at greatest risk. Among SGAs, risperidone at higher doses carries the most Parkinsonism risk, while quetiapine and clozapine carry the least. How to treat it? First line is dose reduction or switching to a lower-risk antipsychotic. If the antipsychotic cannot be changed, add benztropine 1 to 2 mg BID or trihexyphenidyl 2 to 5 mg BID. Anticholinergics work well for Parkinsonism because the problem is dopamine acetylcholine imbalance. Amantadine 100 mg. BID is an alternative that avoids anticholinergic side effects. Important caveat: anticholinergics should be used cautiously in elderly patients. Risk of confusion, urinary retention, constipation, and cognitive decline. Amantadine is often preferred in this population. Bored pearl. A subtle early sign of DIP that the exam loves to test is decreased arm swing while walking. This can be detected before the classic tremor and rigidity appear. Memory trick. Parkinsonism equals progressive over weeks equals pill-rolling tremor equals treat with anticholinergics or amantadine. Tardive dyskinesia, the uninvited guest who won't leave. Months to years. What it is. Tardive dyskinesia, TD, is the late-onset movement disorder, developing after months to years of antipsychotic exposure. The word tardive literally means late. It presents as involuntary, repetitive, purposeless movements, most commonly lip smacking, tongue protrusion, chewing movements, puckering and grimacing, orofacial region, but can also involve finger writhing, toe movements, trunk rocking, and pelvic thrusting. TD is potentially irreversible, which is what makes it the most feared of all antipsychotic side effects. The numbers. The annualized incidence is approximately 6.5% with FGAs versus 2.6% with SGAs. The overall prevalence is about 24 to 30% with FGAs and 13% with SGAs. Among SGAs, olanzapine and aripiprazole have the lowest TD risk, while risperidone has a relatively higher risk. Clozapine and quetiapine are associated with the lowest TD risk overall. Risk factors. The most consistent risk factors are older age, especially greater than 55, female sex, particularly postmenopausal women, longer duration of antipsychotic treatment, higher cumulative doses, early development of acute EPS. Parkinsonism or akathisia. These are warning signs that TD may follow. Mood disorders, especially major depression, neurological conditions, alcohol use disorder, and diabetes. Screening. The Abnormal Involuntary Movement Scale, AIMS, is the gold standard screening tool. It should be performed at baseline before starting any antipsychotic, then every 6 to 12 months for most patients, every 6 months for patients on FGAs, and every 3 months for high-risk patients. Elderly on FGAs. The AIMS examines 7 body regions for involuntary movements: face, lips, jaw, tongue, upper extremities, lower extremities, and trunk. Each is rated 0 to 4, none to severe. Proactive screening is essential because TD is often mild at onset and escapes notice. Early detection allows intervention before movements become permanent. Treatment. 2 FDA-approved VMAT2 inhibitors are first-line: valbenazine, Ingrezza, dosed once daily starting 40 mg, target 80 mg, and deutetrabenazine, Austedo, dosed twice daily starting 6 mg BID, titrated up. A once-daily formulation is now available. They work by inhibiting vesicular monoamine transporter 2, which depletes presynaptic dopamine and reduces involuntary movements. Other strategies include switching to a lower-risk antipsychotic, quetiapine or clozapine. The APA recommends VMAT2 inhibitors for moderate to severe or disabling TD. Bored pearl, anticholinergics, benztropine can actually worsen tardive dyskinesia. They help acute EPS, dystonia, Parkinsonism, but hurt TD. This is because DIP and TD have opposite pharmacological mechanisms. DIP equals too little dopamine activity leads to add anticholinergics to compensate. TD equals dopamine receptor supersensitivity from chronic blockade leads to anticholinergics remove the last brake on the system. Memory trick. Tardive equals too late equals tongue movements equals treat with VMAT2 inhibitors, not anticholinergics. Neuroleptic malignant syndrome, NMS, the silent killer. What it is: NMS is the most life-threatening complication of antipsychotic use, a rare 0.01 to 0.04% of patients on antipsychotics, but potentially fatal idiosyncratic reaction caused by sudden, massive dopamine blockade. The mortality rate remains approximately 10% even with modern management, historically 10 to 20% with FGAs, approximately 5.5% with SGAs. It typically occurs within the first 1 to 2 weeks of starting or increasing an antipsychotic, but can occur at any time. Unlike the other movement disorders, NMS is a medical emergency requiring ICU-level care. The 4 cardinal features, remember, FARM. F equals fever, temperature greater than 38 degrees Celsius / 100.4 degrees Fahrenheit, often spiking to 40 degrees Celsius plus. A equals autonomic instability, tachycardia, labile blood pressure swinging between hypertension and hypertension, diaphoresis, tachypnea, sialorrhea. R equals rigidity, lead pipe rigidity, severe, generalized, continuous resistance to passive movement in all directions, unlike the cogwheel rigidity of Parkinsonism. M equals mental status changes, delirium, confusion, mutism, stupor, or coma, often the earliest sign appearing before fever and rigidity. Key lab findings: massively elevated creatine kinase, CK, often greater than 10,000 units per litre, sometimes greater than 100,000, from rhabdomyolysis, muscle breakdown from sustained rigidity. Also leukocytosis, elevated WBC, typically 10,000 to 40,000. Metabolic acidosis, elevated liver enzymes, LDH, AST, hypercalcemia, hyperkalemia, and characteristically low serum iron. Critical caveat: CK may be normal early in the course. A normal CK at onset does not rule out NMS risk factors. Higher doses or multiple antipsychotics, high-potency FGAs. Haloperidol is the classic culprit. IM/IV administration, rapid dose escalation, male sex, young adults, dehydration, agitation, catatonia, previous NMS episodes, and developmental disorders in children. Treatment: the tiered approach. Step 1. Stop the antipsychotic immediately. This is the single most important intervention. For oral medications, drug levels typically fall within 3 to 5 days. For long-acting injectables, LAIs, the drug persists for weeks to months in the muscle depot, making LAI-associated NMS more prolonged and dangerous. Step 2. Aggressive supportive care in the ICU. IV fluid resuscitation, target urine output 200 to 300 milliliters per hour to prevent rhabdomyolysis, induced renal failure. Cooling measures for hypothermia, evaporative cooling with mists and fans, surface thermoregulation devices, acetaminophen 1,000 milligrams every 6 hours for fever, correction of electrolyte abnormalities, especially calcium, potassium, magnesium, stress ulcer prophylaxis, DVT prophylaxis with subcutaneous heparin, and continuous monitoring of vital signs, renal function, and CK. Step 3. Pharmacological treatment. Indicated when core temperature reaches 38 to 40 degrees Celsius and rigidity is moderate to severe. Lorazepam can help with mild rigidity and is often tried first. Dantrolene is a direct-acting skeletal muscle relaxant that inhibits calcium release from the sarcoplasmic reticulum. It reduces rigidity and hypothermia and lowers CK levels. Monitor liver function with dantrolene. Hepatotoxicity risk at high doses. Bromocriptine or amantadine are dopamine agonists that counteract the dopamine blockade causing NMS. Evidence for these specific treatments remains mixed. A systematic case series analysis found that specific therapies, dantrolene, bromocriptine, ECT, did not reduce overall mortality, but were associated with substantially lower mortality in severe NMS cases. 10% versus 30% with symptomatic therapy alone. Step 4. ECT, electroconvulsive therapy, may be considered for refractory cases, particularly when catatonic features are prominent. ECT showed the lowest mortality rate among specific therapies in severe NMS after NMS resolves. Wait at least 2 weeks before cautiously restarting an antipsychotic. Choose a different chemical class, preferably a low-potency SGA like quetiapine or clozapine. Start at the lowest dose and titrate very slowly with close monitoring. The recurrence risk with re-challenge is estimated at 10 to 30%. Bored Pearl NMS from a long-acting injectable lasts longer because the drug can't be stopped. It's already in the muscle depot and will continue releasing for weeks to months. Versus NMS versus serotonin syndrome, the ultimate bored comparison. This is one of the most tested differentials on PMHNP boards. Both cause fever and altered mental status, but the clinical features are distinctly different. NMS is caused by dopamine blockade, antipsychotics. It develops slowly over days. The hallmark is lead pipe rigidity, severe generalized continuous resistance. Reflexes are normal or decreased. There is no clonus. Pupils are normal. CK is massively elevated. Think rigid and slow. Serotonin syndrome is caused by serotonin excess. SSR is, SNR is, MAO is, triptans, tramadol, linezolid, St. John's wort. It develops rapidly over hours. The hallmark is clonus, rhythmic involuntary muscle contractions, especially in the ankles, plus hyperreflexia, and myoclonus, sudden muscle jerks. Pupils are dilated. Bowel sounds are hyperactive. Diarrhea is common. CK may be mildly elevated, but not massively. Think twitchy and fast. The NEJM comparison table makes the distinction crystal clear. NMS has +++ rigidity, no hyperreflexia, +++ hypersalivation, and +++ elevated CK. Serotonin syndrome has plus rigidity, +++ hyperreflexia, ++ hypersalivation, and plus elevated CK. The single most specific finding for serotonin syndrome is clonus. If you see clonus, it's not NMS. Memory trick: NMS equals no clonus, massive rigidity, slow onset. SS equals sudden onset, clonus and shaking, serotonin excess. The master timeline cheat sheet: hours to days to acute dystonia to treat with iambenztropine or diphenhydramine to reversible, days to weeks to akathisia to treat with propranolol, mirtazapine or vitamin B6. Reversible, reduce dose first. Weeks to months, drug-induced Parkinsonism. Treat with benztropine, trihexyphenidyl or amantadine. Reversible months to years, ARO, tardive, dyskinesia. ARO treat with VMAT2 inhibitors, valbenazine/deutetrabenazine, ARO, potentially irreversible. Days to weeks, ARO NMS, the emergency. ARO stop drug, ICU, dantrolene/bromocriptine leads to potentially fatal 10% mortality. Quick-fire practice questions. Question 1. A 20-year-old male receives haloperidol 10 milligrams IM. 6 hours later, his eyes are deviated upward and his neck is twisted to the right. What do you give? ARO IM benztropine 1 to 2 milligrams or IM diphenhydramine 50 milligrams, acute dystonia. Q2. A patient on risperidone says, "I can't sit still. I feel like I'm going to jump out of my skin," but denies worry or racing thoughts. What is it? ARO akathisia, not anxiety, no cognitive symptoms. Q3. You increase the antipsychotic dose for a patient you think is agitated. The patient gets worse. What did you miss? Akathisia. Increasing the dose made it worse. Should have reduced the dose or added propranolol/mirtazapine. Question 4. A patient on haloperidol for 3 years has lip smacking and tongue protrusion. You start benztropine. What happens? The movements get worse. Anticholinergics worsen tardive dyskinesia. Should have started a VMAT2 inhibitor. Question 5. A patient develops fever 104 degrees Fahrenheit, lead pipe rigidity, CK 45,000, and confusion 10 days after starting an antipsychotic. Diagnosis: NMS. Stop the drug. ICU. IV fluids. Dantrolene. Question 6. Same scenario, but the patient has clonus, hyperreflexia, dilated pupils, and diarrhea after starting an SSRI plus tramadol. Diagnosis: serotonin syndrome. Stop serotonergic agents, supportive care, cyproheptadine. Q7. Which screening tool is used for tardive dyskinesia, and how often should it be done in a 75-year-old on haloperidol? AIMS every 3 months. High risk, elderly, plus FGA. Q8. A patient recovers from NMS. When can you restart an antipsychotic? And which one? Wait at least 2 weeks, choose a different class. Low potency SGA like quetiapine or clozapine. Start at the lowest dose, titrate slowly. The 5 deadliest exam traps. Patient is agitated on antipsychotic, leads to increase the dose, leads to could be akathisia. Increasing the dose makes it worse. Benztropine for tardive dyskinesia. Wrong. Anticholinergics worsen. TD. Use VMAT2 inhibitors. Normal CK rules out. NMS. Right arrow. Wrong. CK can be normal early. Look at the full clinical picture. FARM. NMS and serotonin syndrome are the same thing. Why a right arrow wrong? NMS equals rigid and slow. SS equals twitchy and fast. Look for colonus SS versus lead pipe rigidity, NMS. Activated charcoal for NMS. NMS is not a poisoning, it's an idiosyncratic reaction. Treatment is stop the drug plus supportive care plus dantrolene/bromocriptine. This guide synthesizes the key movement disorder concepts from the current evidence base, including the NEJM review on NMS, distinguishing it from serotonin syndrome by the presence of lead pipe rigidity versus clonus and hyperreflexia, the 2024 JAMA Network open meta-analysis showing mirtazapine and vitamin B6 as the most effective treatments for akathisia, the APA's recognition of NMS as a form of malignant catatonia treatable with dantrolene, bromocriptine and ECT, and the DSM-5 risk factor profile for tardive dyskinesia, emphasizing age and cumulative antipsychotic exposure as the most important predictors. The treatment algorithms reflect current evidence that specific NMS therapies, dantrolene, bromocriptine, ECT, show the greatest benefit in severe cases.
Thanks for watching. Like and subscribe for more content.